Assalamu alaikum and welcome to the last but not the least session of our program. One good thing is to see the chairs are still full. That means our speakers are very good and they're able to attract the interest of the audience. With that, I welcome Dr. Osman. He's a consultant and working in gastroenterology department in Jahra hospital. He's got an MD from Mumbai and an MRCP from UK, and he will talk to us about the peri-endoscopic management of antithrombotics. Over to Dr. Osman. Thank you.
Thank you very much, Dr. Thomas. It was a very kind introduction. My topic today, the management of antithrombotics in patients undergoing GI endoscopy, is quite interesting. You know, we know about drug-drug interaction, but here we are going to discuss a procedure and a drug interaction. Like endoscopy is a procedure, and what will be the effect of the drugs, that is the antithrombotics. How do we manage these patients who are on antithrombotics and they have to undergo some sort of a GI endoscopy? Now, a little back in time, endoscopy was initially introduced as a diagnostic tool, and it has evolved a great deal, and we are able to perform many therapeutic interventions with the help of endoscopy. Similarly, the antithrombotics, which are broadly classified as anticoagulants and antiplatelets, they have also evolved from aspirin being introduced over almost 200 years back and warfarin to several new drugs. So we need to study and we need to know exactly what to do. For example, a patient who has got a stent in situ and he comes with bleeding. He has hematemesis. So what do? We have to do an endoscopy. How to do it? When should we stop the antiplatelet agents? Or if he's on anticoagulant, whether to stop? For how long do we stop these drugs? And more importantly, when should we restart all these drugs? So are there any guidelines? We'll just go through my presentation today. So this is a specimen of an endoscopy request. This is a specimen of an endoscopy request, and we see this part where the physician who is requesting an endoscopy has to mention whether the patient is taking any anticoagulant or any antiplatelet agents. This is a very important part which has to be filled by all the physicians who are requesting endoscopies. My talk today is based on these guidelines which were published by the American Society of Gastroenterology late in 2016. I have some inputs from other sources as well, because though it was released in late 2016, there are some more recent guidelines, some more recent papers which have changed some numbers, and I'll talk about that during my presentation. And simultaneously, I would disclose that there are no financial support from any of the drug companies. Now coming to the main topic, the antithrombotic therapies are mainly used in patients having atrial fibrillation, acute coronary syndromes, venous thromboembolism, or DVT, hypercoagulable states, and endoprosthesis, especially the drug-eluting stents or the mechanical heart valves. These are the commonest things which are being used. As I said, these antithrombotic agents are broadly classified into two classes, that is the antiplatelet agents and the anticoagulants. The anticoagulants, the oldest one, which is the vitamin K antagonist, as we know as warfarin. Then the newer ones, these are direct factor Xa inhibitors and the direct thrombin inhibitors. And the antiplatelet agents, that is aspirin, and the newer ones, which are the P2Y12 inhibitors or thienopyridines, such as clopidogrel, prasugrel, ticagrelor. As a patient is undergoing or is supposed to undergo an endoscopy, there are certain considerations which come into the mind. The urgency of the procedure, the bleeding risk of the procedure, the effect of the antithrombotic agents on the bleeding risk, and what will happen if the antithrombotic agents are stopped and the patient has a high risk for thromboembolic episode. So we'll go through all this during my presentation. First, we come to the point of the risk of the procedure itself, whether the procedure is high risk or a low risk for bleeding. In general, the diagnostic procedures That is the diagnostic upper endoscopy, the colonoscopy. The diagnostic procedures are generally low risk for bleeding, whereas the therapeutic procedures, or the procedures where a patient needs to undergo some sort of intervention, the simplest one being is the polypectomy. It increases the risk of bleeding in a patient. The list is quite long. I'll not go through the whole list. We'll go to the other part. Now, coming to the risk of thrombosis in patients. Classically, it is described with warfarin therapy. So what are the high-risk conditions for thrombosis? These again can be classified into two groups. Those with mechanical heart valves, such as any mitral valve prosthesis, any caged ball or disc aortic valve prosthesis, or recent CVA or TIA, that is within 6 months. Similarly, in patients having thromboembolism, recent thromboembolism, venous thromboembolism within 3 months, severe thrombophilia, that is severe protein C or protein S deficiency, or antiphospholipid antibodies, or multiple abnormalities. There can be a combination, overlap of multiple deficiencies. And the low risk is bileaflet aortic valve prosthesis without atrial fibrillation and no other risk factors. In thromboembolism, that is venous thromboembolism, which has occurred more than 12 months back. And there are no risk factors. Or in other words, we don't know the exact cause of thromboembolism. Now, similarly, what are the high thrombosis risk scenarios for patients on antiplatelet agents? These are drug-eluting stents in coronaries for the previous less than 3 months, bare metal stent for previous 4 to 6 weeks, and PTCA with balloon dilatation up to 2 to 4 weeks prior, are patients with prior history of stent occlusion. Like in the primary, in the paper which I showed, the numbers were different. The numbers have changed depending on the availability of the data. Initially, it was said that drug-eluting stent in coronaries for up to 12 months was supposed to be high risk for thrombosis. As the data is becoming available, the duration, the numbers have changed. I would just go through the agents which are being used as antiplatelet agents and later on the novel oral anticoagulant drugs. The antiplatelet agents classically is the aspirin, that is cyclooxygenase inhibitor. It is used for secondary prevention of MI and stroke, and duration of action is about 7 to 9 days. Thienopyridine drugs, which inhibit the P2Y12 component of the ADP receptors on the platelets. The initial one which was introduced was ticlopidine. It went out of vogue because of the hematologic complications, mainly TTP. The drugs which are being currently used is clopidogrel, as we know as Plavix. It is used in the secondary prevention of MI, stroke, and peripheral vascular disease. Duration of action lasts for almost 5 to 7 days. Clopidogrel and prasugrel need to be converted to the active metabolite, whereas ticagrelor, which is a more recently introduced drug, it is also a P2Y12 inhibitor, and it is quickly absorbed, it is metabolically active, and has rapid antiplatelet effect. It has shorter duration of action of 3 to 5 days. Knowing the pharmacokinetics is important because that will decide on when to interrupt these drugs and when to restart them. A new drug which has been recently introduced, that is in 2014 January, though it is not so widely used, is Vorapaxar, which has got a very long duration of action of almost 4 weeks, and it has got more risk of bleeding. It comes with a black box warning in patients with history of stroke, TIA, or intracerebral hemorrhage. These drugs, these 3 tables, there are 3 drugs, that is the dabigatran, rivaroxaban, and apixaban. Here, if you see that the onset of action of all these drugs is around 1 to 4 hours. The half-life depends on the creatinine clearance. As the creatinine clearance reduces, the half-life is prolonged. This is again very important, as I said, to decide when to interrupt these drugs before doing any procedures and for how long it has to be interrupted. Like in patients who is undergoing a high-risk procedure and he's on dabigatran with a creatinine clearance of less than 29, will have to stop this drug for almost 4 to 6 days prior to a procedure. The patients who are on anticoagulants, though here it is written for warfarin, warfarin is the classical anticoagulant which was being used for a long time. where do we need to put a patient on a bridge therapy? So in patients who are having atrial fibrillation and having no risk factors, no associated risk factors, or the chest to vascular score is less than 2, there is no bridge recommended. Whereas those patients who are on mechanical valves with history of cardiovascular accident and chest to vascular score of more than 2, bridge therapy is recommended. Similarly, in patients with valvular heart disease, bileaflet mechanical aortic valve replacement, there is no bridge therapy recommended. Whereas patients having mechanical aortic valve replacement and any thromboembolic risk factor, older generation mechanical aortic valves, mechanical mitral valve replacement, bridge therapy is recommended. Similarly, for patients on antiplatelet agents or dual antiplatelet therapy, avoid cessation of all antiplatelet therapies after PCI with stent placement. Avoid cessation of clopidogrel even when aspirin is continued within the first 30 days after PCI and DES or drug-eluting stent placement or BMS placement. Defer elective endoscopic procedures, possibly up to 12 months, if clinically acceptable from the time of PCI or DES placement. Perform endoscopic procedures, particularly those associated with bleeding risk, 5 to 7 days after stopping the thienopyridines, that is clopidogrel or prasugrel. Aspirin should be continued. Resume thienopyridines and aspirin drug therapy after the procedure once hemostasis is achieved. A loading dose of the former should be considered among patients at risk for thrombosis. Continue platelet-directed therapy in patients undergoing elective endoscopy procedures associated with a low risk for bleeding. So now we have seen about stopping the antiplatelet and the antiplatelet and the anticoagulants. So what about reinitiation? There is a consensus that therapy should be resumed upon completion of the procedure. The AHA-ACC guidelines recommends that warfarin should be started within 24 hours of the procedure in patients with valvular heart disease and low risk for thromboembolism. In high risk for thromboembolism, unfractionated heparin or low molecular weight heparin should be restarted as soon as the bleeding stability allows and continued until the INR reaches the therapeutic level. Unfractionated heparin can be restarted 2 to 6 hours after the therapeutic procedure. For low molecular weight heparin, there is no optimal time has been determined yet. In 2012, the ACCP recommends delaying reinitiation up to 48 to 72 hours in high risk for bleeding patients. Regarding NOACs, the optimal timing of reinitiation, there is no data yet because they have short onset of action. If NOAC cannot be restarted within 24 hours after a high-risk procedure because of concern regarding adequate hemostasis, then bridge therapy should be considered in patients who are at high risk for thromboembolism. Cardiac aspirin should not be stopped in most cases. Other antiplatelet agents should be resumed once hemostasis has been achieved. What about endoscopic procedures in acutely bleeding patients who are on antithrombotics? Endoscopic therapeutic procedure is very effective in patients with moderately elevated INR. Normalizing the INR does not reduce the rebleeding, but it does delay the time for doing the procedure. And INR at the time of endoscopy may not be predictive of rebleeding. It is reasonable to perform an endoscopic procedure in bleeding patients with INRs less than 2.5. The decision to stop, reduce, or reverse the antithrombotic therapy must be weighed against the risk of continued bleeding. ACCP recommends that warfarin be held and rapid reversal of anticoagulation in patients having major bleeding with PCC, that is prothrombin concentrate complex, and additional use of vitamin K. But AHA-ACC, the 2014 guideline on management of valvular heart disease recommends that FFP or PCC is reasonable in patients with uncontrollable bleeding, high dose of vitamin K, that is not exceeding up to 5 milligram of vitamin K should not be given routinely. In massive hemorrhage, hemodialysis can be used in patients dabigatran, though there are new drugs such as idarucizumab and aripazine and andexanet alpha, which are the drugs which are used to reverse the actions of dabigatran, rivaroxaban, and apixaban. What about endoscopic procedures in acutely bleeding patients on antiplatelets? For patients on aspirin or antiplatelet agents with life-threatening or serious bleeding, options include stopping these agents and or administration of platelets, resume therapy after endoscopic control of GI bleeding. There is limited data to guide the timing of reinitiation of this therapy. The current consensus statements recommend reinitiation of therapy as soon as hemostasis is achieved. For aspirin-related peptic ulcer bleeding, aspirin with a PPI is preferred to clopidogrel alone. Now, endoscopy in patients with intracoronary stents or acute coronary syndrome taking antithrombotics. Regarding elective endoscopy, use of dual antiplatelet therapy confers a threefold increased risk of bleeding. All elective high-risk endoscopic procedures on dual antiplatelet therapy should be delayed until the minimum length of therapy as recommended by the ACC or ACG guidelines. Once this period has elapsed, the endoscopic procedure can be done after discussing the risk with the patient and the patient's cardiologist or the physicians. What about urgent endoscopy in patients with acute coronary syndrome or recently placed stent? 1 to 3% of patients present with or develop GI bleeding during their index hospitalization with a 4 to 7-fold increased risk of mortality. There is a study of about 200 patients who underwent endoscopy within 30 days. Serious adverse events occurred in only 2 patients, that is just 1%. Patients may develop acute coronary syndrome after GI bleed, and these patients are likely to benefit from the endoscopic procedure. The benefit of endoscopy in setting of acute coronary syndrome is supported by a decision analysis that showed upper endoscopy before PCI. That is, a patient who undergoes endoscopy before doing a PCI to be beneficial in patients who presented with overt GI bleeding in the setting of acute coronary syndrome, reducing the overall deaths from 600 to 97 per 1,000 patients. Endoscopy was not found to be beneficial in patients who present with occult GI bleeding and acute coronary syndrome. Now, I have summarized all the recommendations. These last 4 slides will summarize all the talks so far. What about elective endoscopic procedures in patients on anticoagulant therapy? Elective endoscopic procedures to be deferred till the short-term anticoagulation therapy is completed. Hold anticoagulation for appropriate drug-specific interval in the peri-endoscopic period if high-risk procedures are planned in patients at low risk for thromboembolism. Continue warfarin or NOACs in patients undergoing low-risk procedures. Bridge therapy is recommended for patients undergoing high-risk procedures who are at high risk for thromboembolism. Warfarin should be restarted on the same day as the procedure in all patients who do not have ongoing bleeding. Reinitiation of NOACs after high-risk procedures should be delayed until adequate hemostasis. If NOACs cannot be restarted within 12 to 24 hours, bridge therapy should be considered. What about elective endoscopic procedures?
Sorry to interrupt, 2 minutes.
I'll finish. Less than that. Elective endoscopic procedures in patients receiving antiplatelet therapy. Continue low doses of aspirin and non-steroidals in peri-endoscopic period. Thienopyridines be continued for all low-risk procedures. Discontinuation of thienopyridines at least 5 to 7 days before the high-risk procedure, or switching to aspirin monotherapy until the thienopyridine can be safely resumed. Elective procedures to be deferred in patients with recently placed coronary stents and or acute coronary syndrome until the patient has received antithrombotic for the minimum duration. Thienopyridines should be held for at least 5 to 7 days, in case of ticagrelor about 3 to 5 days before high-risk endoscopic procedures, and aspirin to be continued for patients requiring dual antiplatelet agents. What about urgent and emergent endoscopic procedures in patients on anticoagulant therapy? patients with acute GI bleeding on anticoagulant therapy have anticoagulant agents held to facilitate the achievement of hemostasis, use either FFP, use either 4-factor prothrombin complex concentrate and vitamin K or FFP can be given in life-threatening GI bleeding patients who are on warfarin. Endoscopic therapy should not be delayed in patients with serious GI bleed and INR less than 2.5. Patients who require anticoagulant therapy should receive unfractionated heparin because of its relatively short half-life after successful endoscopic hemostasis for high-risk stigmata. Doing the urgent and emergent endoscopic procedures for patients who are on antiplatelet therapy, consult with the prescribing specialist before stopping antiplatelet agents in situations of significant GI bleeding in patients with recently less than 1 month placed drug-eluting stent, within 30 days after insertion of bare metal stent, or within 90 days of acute coronary syndrome. The risk of an adverse cardiac event associated with cessation of the antiplatelet therapy likely exceeds the benefit of decreasing the peri-endoscopic bleeding. Patients on antiplatelet agents with life-threatening or serious GI bleeding should have these agents held after discussion with their cardiologist. Thank you.